Good evening, friends. Today we are going to discuss another very important topic, that is hypertensive urgency and emergency. And I am going to give you the idea about the clinical approach and treatment for the same. As this is a this is very common situation you may encounter in your casualty and the ICU. And today we will see that how we are going to treat this patient and how we are going to handle this kind of patient. So I will start with the causes. I am going to give you a few selected causes. These are the selected causes, and these are the important you will may encounter very frequently in your day-to-day OPD or in your duties. So first and foremost is essential hypertension. As patient is already a known case of hypertension and he is taking medication irregularly, so he is not taking antihypertensive regularly, so that can lead to raised peripheral vascular resistance that shoots the BP, that shoots his BP. Second, very important topic is CVA, that is cerebrovascular accident. Means patient has some risk factor for the CVA. Patient might be smoker, might be drug addict. He got a CVA which raised his peripheral vascularization. This shoots the BP. Third, you may see in the ICU, that is burn and post-operative patients, when there are very stress is very high, so the stress hormones are very high in the body is very high, which leads to increased peripheral vascular resistance and which leads to hypertension, which can shoot his BP. It causes hypertension. In the endocrine system, we see only two causes, that is pheochromocytoma and Cushing syndrome. These are the two very common diseases you may encounter in your day-to-day practice, and they also presented with hypertension. We will see later on how we are going to diagnose them. In the renal artery stenosis, as you know, there is a young patient. They came to you with hypertension. You always hypertension, and we always suspect them renal artery stenosis, which can lead to high blood pressure. In the drugs abuse patients who are chronic abuser or IV abuser, the cocaine and amphetamine are the two common drugs that can cause very high BP. So here, these are the few common causes for which you can see in your OPD and IPD. So first we need to differentiate between the emergency and urgency. When we call the patient, when we call that this is an emergency, or when we say this is an hypertensive urgency. So emergency, we can easily remember with mnemonic that the name is bigger, the problem is bigger. So emergency have much more problem when we compare with urgency. So I mean, the criteria for blood pressure is same for both. The systolic BP in both situations is more than 180 and diastolic more than 120. We will say that yes, they can be hypertensive urgency and emergency, but in emergency, patient is significantly symptomatic. The patient has significant end organ damage in the emergency. So end organ damages are there. Once there are damage, so there are symptoms. So how we know that there is end organ damage? The patient have high BP, let's say 180 by 120 as we see the cutoff, and the patient is having MI, patient is having CVA, patient is having decreased vision or blindness. So as we know that in the heart, brain and eye we have end organ arteries, so there is damage. Patient presented with chest pain with very high BP, you get a ECG, and you may know that he is having anastomia or anastomia, MI. Patient have unconscious or an altered sensorium with hemiparesis. You make the diagnosis of CVA with high BP. So then we will come to know that this is hypertensive emergency. So these are the few common symptoms by which we can know that there is end organ damage. And for the hypertensive emergency, we need to admit patient in ICU and start the IV antihypertensive. So once patient came to you with emergency, we have to start we might need an IV antihypertensive to control the BP efficiently. Later on, we can shift the patient to oral drugs. In hypertensive urgency, the BP is same more than 180 by 120, but there are minimal or no symptom. There is no symptom at all. The patient might come to you in a OPD with, let's say, BP is 120 by 130 and he or she may not have any symptoms. So this is hypertensive urgency as there is no end organ damage. So they can manage at OPD, or if you want, you can ask the patient to admit in the general ward for monitoring of the BP, and they can manage with oral drugs very well. So these are the two differences. in the between the emergency and urgency. Now we have to see what are our targets of blood pressure for this category. Means once we get a patient with hypertensive emergency, how we are going to decrease the BP and how much the BP needs to be reduced within a set period of time. So for the hypertensive emergency, as we know, there is end organ damage. We have already seen there is end organ damage. So the BP must be reduced more in less time. So we required a reduction of 20 to 25% of pre-treatment blood pressure within 6 hours only. So once we have admitted the patient, within 6 hours, we need to reduce the BP to 25%. Let's say example, if systolic BP is 200, we need to reduce it to 160 or 150 within next 6 hours, right? So for to achieve this target, we might need IV antihypertensive as well as infusion of antihypertensive drug. So we need immediate reduction in the BP. So we prefer short and immediate acting drug. Rapid acting drugs are preferred so that we give the drug, patient got action, the BP is reduced. So in the emergency, we need to reduce the BP more. While we compare with hypertensive urgency, as we know, there are no symptoms, patient is asymptomatic or there are symptoms are very mild. So there is no need for hurry worry. So you can admit the patient in general ward. Let's say you have admit the patient come to UPD, you admit in general ward for monitoring, and then you can start with oral drugs. So what is our target? We need to reduce 15 to 20%, max to max 20% reduction. First 24 hours. The window is here longer, 24 hours. Emergency is 6 hours. So first in the first day, if we reduce the BP to 20%, we see that yes, our target is achieved, and now we can monitor the patient. If target can be achieved on oral drugs, they might not be IV. There might not be requirement of IV drugs, and the monitoring is required. You can monitor the patient at home or in the general ward wherever you have admitted. So here also rapid acting drugs are required. Why rapid acting drugs are preferred? Because yes, the window is longer, but yes, we need to reduce the BP. One in your clinical practice, if a patient came to you with 180 by 130 BP, so the moment he see his BP, what is increases is his anxiety, and the once the patient become anxious, he expect from you to reduce a BP. So you have to reduce his or her BP efficiently. If you fail to do, he will find some other else to reduce the BP. So in the OPD, you have to manage these things also. You have to satisfy the patient both physically, psychologically. Once you have admitted the patient for hypertensive emergency, once we have admitted the patient in ICU, now we will see the drugs. What are the drug options? What their brand name and their strength, and how we can start the drugs to monitor the BP. First and foremost is sodium nitroprusside, a very commonly used drug in medicine ICU or casualty. It available in the market with the name of nitropress or nipride. The strength it is available in the IV form, and we have to start with 0.5 to 10 microgram per kg per minute. Let's say the weight is 60 kg. The patient came to you with 60 kg. So how we going to start? We will start with 33 milligrams of drug per minute. We will start the infusion at 3 milligram per minute, right? We will start with the lower doses. If the response is not there within 1 hour or within 30 minutes, we can increase the dose up to the 10 microgram per kg per minute, right? Onset of action is within seconds. So this is what we ideally required. And what we have to cautious about it in the CKD patient, if you are dealing with CKD patients, so we need to avoid the nitroprusside. As we know, they have cyanide component, so they can accumulate in the body and can lead to cyanide poisoning. Another agent is esmolol, very commonly available, named with Isogard or Esmogard, and then we have to give 30 milligram bolus followed by 50 microgram per kg per minute infusion. Onset is within minutes, 1 to 2 minutes. The onset is there, and we have to cautious about heart block. If the patient is having SA or AV node block, then you may avoid this agent. You can go sodium nitroprusside or some other agent. So dose is there. Third agent we have in IV form is nitroglycerin, that is available as nitrosate or myonate. The infusion we have to start with 10 microgram per kg per minute, and we can increase the infusion if there is no response. Onset is within minutes. A few side effects are there, like headache and flushing. We can avoid that. We are not worried about these symptoms, well, because we have many more things to do. The 4 is very common drug available and used in the medicine ICU is labetalol, available as low bit 50 milligram K vials it is available in the market, and we have to give 20 to 80 milligram bolus in every 10 minutes. Let's say patient came to you and you give 40 milligram bolus and you see the response in 10 to 20 minutes. Onset, as we see, onset is within 5 to 20 minutes. So you give the 40 milligram bolus, you see the response. If BP is reduced, you will continue with that. If not, then you will increase the dose. And in the COPD patient, we need to cautious about it. As we all know, it can cause bronchoconstriction, so it can exacerbate the COPD and heart failure. So in that category of patients, labetalol must be avoided. So these are the very common four drugs available in our ICU for immediate reduction of BP as IV. In the hypertensive urgency, as we know that we can manage the patient in oral drugs. So we will start with oral drugs only. So first is short acting is captopril. As we know, we need short and immediate acting drug. Captopril available as angiopril in the market, and this is the extent available in the market, 12.5 and 25 milligram. And onset is within 15 minutes to 60 minutes. You can start with angiopril. What we have to cautious about is renal artery stenosis. As we all know, this is the angiotensin converting enzyme inhibitor. So in a bilateral renal, if there is a bilateral renal artery stenosis, it will completely suppress the RAS system, and that will lead to renal shutdown. So in the bilateral renal artery stenosis, we have to cautious. If there is a case, we can shift to another. We have another potent agent, nifedipine, very frequently available and used, and all of you must have heard Nicardia or Depin. Available strength is 10 to 20 milligrams per oral. These are the tablets. Onset is within 10 minutes, within 20 minutes. The only problem with Dipin is sudden hypotension. As we know, it causes peripheral vasodilation. So vascular constriction or peripheral vascular resistance, which is increased in these patients, is suddenly fall, and the BP might fall abruptly. So this can be a problem only. Otherwise, this is a very good drug for the urgency. Another drug we have already said is labetalol, available as low weight in 50 milligram tablets. So we can start with 50 milligram OD or BD, and responses came within 30 to 120 minutes. We will monitor the patient. If this is the case, COPD or heart failure, we need to avoid it. Another agent is clonidine, that is centrally acting antihypertension, and available in the market as Arkamine. The strength available are 0.1 milligram or 100 microgram, or 0.2 milligram or 200 microgram. So onset is within 30 minutes. We can start with 100 microgram BD or TDS. Based on thrice a day, we can monitor the patient. And the only problem with this is rebound hypertension. The amlodipine, a very good drug. If we have newly detected hypertension patient, amlodipine is a very good drug. So we can start amlodipine. Available in the market is 5 to 10 milligram of strength. We can start with OD, 5 milligram OD. We can monitor the blood pressure. If it comes to normal, we can continue with that. Otherwise, we can increase the dose. Well, now the patient is already in our ICU or in a ward. You have admitted the patient, you have controlled the BP, and now the next thing is monitoring. We have to monitor the patient, and when we have to discharge, we need to advise the oral drugs to follow up. So once we have controlled the BP below 160, now the short acting drugs can be switched to longer acting. What is the problem with short acting? They need higher frequency. They require to give one twice or thrice a day. So the compliance can be poor in that case. Compliance is poor when the frequency is high. So we need to give once or twice a day only, preferably once a day. So what are the options for home therapy? These are the very common antihypertensive drugs. They are available in the market. Many of you will be familiar with that. We will start with ACE inhibitors. We have very good two very good drugs in the market, that is Remipil and Lisinopril. Lisinopril is longer acting than Remipil, so it's better to start with Lisinopril. Strength are 2.5, 5 and 10 available in the market with brand name of Lisoril, or you can start Remipil name with Cardase 2.5 or 5. You can give once or twice a day and you can monitor the BP very easily. Another very good category is angiotensin receptor blocker, the ARB, and three very common drugs used in hypertension is telmisartan, olmesartan, and losartan. The brand name are very easy to remember. The telmisartan we have Telma, Telmican, and Tajlop. Strength available is 20, 40, 80. Right? In the losartan we have Losar or Losakind. Strength is 25 to 50 in the market. And olmesartan we have Olmesar or Olmegest. Strength is 20 or 40. We can start with 40 milligram, any one of them. We can monitor the BP. If there is no response, then we can increase the dose. If there is no response, we can combine it. And the third category is calcium channel blocker. As we know, amlodipine and cilindipine. Amlodipine available is Amlovas or Amlokind 2.5, 5 or 10. If there is patient having edema, or the only problem with amlodipine is edema, ankle edema. So if you got patient who having ankle edema, so you can give S amlodipine. There is a container of amlodipine available in the market. Strength is same. You can give that. The edema is much less with S amlodipine. And we have cilindipine also, that is also safer in edema patients. Cilindipine we have available with Cilacar, Cilahat or Nexavas. The strength is 5, 10 or 20. So Nexavas is a very common available in India market. We are very frequently using Cilacar, Cilahat or also well-known brands of cilindipine. Beta blockers we have in a very good category. If patient is cardiac patients, so we need to give these are the very good category. So cardioselective beta blockers are preferred over non-selective. And we have carvedilol, bisoprolol, and nebivolol. Carvedilol we have Cardiovas 3.125 or 6.25 milligram. For nebivolol we have Nebicard or Nebistar 2.5 or 5, or for bisoprolol we have Concor 2.5 or 5. These are the brand name with their strength available in the market. You can start with these drugs. One thing you need to remember is ACE inhibitor and ARBs. These two categories are never combined. ACE inhibitor plus ARB. These are never used in hypertension. Reason, they both causes hyperkalemia. So once you combine with these two drugs, the risk of hyperkalemia is very high. So these two drugs are never combined, and cardiologists never prefer to give these two drugs. So we came to the case study. First, you are in casualty. We will see the response. We will see the case. We are in the casualty working with working duty doctors. So you got a 50-year-old male, and he is a well-known case of hypertension, and he has came to you in the OPD with headache and ghabrat. You know the patient is hypertensive, complaining of headache and ghabrat, and he has stopped his medication and started some Ayurvedic treatment. Another very common problem in India, the patient may more rely on Ayurvedic treatment. So we have vitals. The pulse is 110, BP is 194, BP is 194 by 116. So what we got, she is having minimal symptoms, headache and ghabrat only. BP is very high. So the diagnosis is hypertensive urgency. So once we know the diagnosis, so we can conclude that we don't have any end organ damage, as there is no symptom as well. Saturation also, patient is conscious oriented. I did hidden, but GCS is 15. So patient is well. We can manage the patient on OPD basis, or we can give. So diagnosis is hypertensive emergency. How to manage? We can start with oral antihypertensive. We can admit in general ward, and then monitor the BP. The second patient we have 70-year-old female, and she is brought by his son, and the complaint is sudden loss of consciousness. The vitals we have got, she is having bradycardia, pulse is 215, very high BP, low saturation with 5 GCS. So what we got is she is having severe symptoms, very critical. GCS is only 5, BP is very high. So case is hypertensive emergency. So urgently we need to admit him in ICU. And the working diagnosis is hypertensive emergency with as we can conclude with the HT, there is might be a CBA. As we know, there is a loss of consciousness, and the pulse is high, means he is having Cushing's reflex. Cushing's reflex means raised ICT with bradycardia. Right, so we will admit him in ICU. We will intubate the patient to maintain the saturation. We will start IV antihypertensive, and then accordingly we will go for the CT scan and rule out the. In third case, we have a very young male, that is, he is 19-year-old male, and he is came to OPD with complaint of persistent headache and blurred vision. If we listen to the history since here that he is having headache and blurred vision, and 19-year-old, we will misdiagnose as migraine, and we will start with some painkiller. But as he is having blurred vision, means there is difficulty in vision, so your duty is to send the patient for ophthalmic examination. Once you have sent it, you reveal that he is having old vitreous hemorrhage and few floaters also. So this we got a red flag sign that he is having vitreous hemorrhage. A young patient is not, it's not, we are not expecting this, but yes, he got this. So vitreous hemorrhage, so we monitor his vitals. We see that BP is this 198 by 180, but GCS is okay. So patient is very high BP. BP is very high. Yet symptoms are less. At this stage, the less symptoms. GCS is 15. Patient is conscious. He is in our OPD. So how you going to proceed the examination? When you get a young patient with hypertension, very difficult to examine. You need to go a series of investigation to diagnose the patient. What is the pathology that causing hypertension in this young boy? So you may go for ECG or 2D echo. You need a USG whole abdomen to rule out there is any adrenal pathology or tumor. You need a renal color Doppler, renal artery Doppler. It's not venous Doppler, it's artery Doppler. So renal artery Doppler to diagnose renal artery stenosis. You have to go for thyroid profile for hypo or hypothyroidism. So as the number of investigation you need, you start with the basic, go for the just ECG and echo. CBC you get a USG ultrasound whole abdomen. Then you ask him to go for renal artery Doppler and thyroid profile. Once you got all the reports, you can conclude with the diagnosis. If yet diagnosis is inconclusive, apart from these investigations, you can go more for serum fasting cortisol level to diagnose the Cushing syndrome. You can go for blood sugar level if she is having any gluconoma or any blood sugar abnormality. So our diagnosis in terms of hypertensive, our diagnosis is hypertensive urgency. There is no symptoms are very mild, and then we can diagnose or we can evaluate the patient accordingly. So here we see all the cases, the three cases very commonly you will see in your OPD. So good luck for that. I hope you got that how to treat. We have seen the drugs also, their dosage, the brand names, so you can memorize them, and when you're working in a casualty or in ICU, you can use them. Okay, bye bye. Thank you so much.